Hi, I'm Dr. Peter Duboulay, professor of radiology at Harvard Medical School and senior vice chair of radiology at the Brigham and Women's Hospital in Boston. I'll be lecturing on ultrasound diagnosis of early first trimester miscarriage, talking about some of the ways to diagnose miscarriage and some of the errors to avoid making in the diagnosis of miscarriage. First, a little bit of terminology. A miscarriage is defined as spontaneous loss of an intrauterine pregnancy prior to 20 weeks of gestation. What I'm going to be focusing on here is early first trimester miscarriage, between 5 and 7 to 8 weeks of pregnancy. Some other terms that are synonymous with miscarriage, at least early first trimester miscarriage, include early pregnancy failure or spontaneous abortion. The incidence of miscarriage is fairly high. 10 to 25% of all clinically recognized pregnancies end in miscarriage. What do I mean by clinically recognized? That's a woman who is known to be pregnant based on either a positive pregnancy test or an ultrasound showing a pregnancy. It is really not possible to know how many of all pregnancies end in miscarriage, but it is almost certainly much higher than 10 to 25%. This is an interesting statement that was made in an editorial in the journal Ultrasound in Obstetrics and Gynecology in December of 2011, where the editorial writer stated, would it not be worrying if the criteria to pronounce death at any other stage of human life were as variable as those that exist currently in early pregnancy? In other words, the editorial was expressing concern about the fact that in different practices within one country or in different countries, people used different criteria to diagnose miscarriage, whereas there should be standard criteria to diagnose miscarriage. That was in 2011. And in part because of concerns such as those expressed in the editorial about varying criteria to diagnose miscarriage, the Society of Radiologists in Ultrasound put together a consensus conference on early first trimester sonography, guidelines for diagnosing miscarriage and excluding a viable intrauterine pregnancy. That was held in October 23rd to 24th of the year 2012 to try to get standardization of criteria for diagnosing miscarriage. About a year after the 2012 consensus conference, a paper came out from that conference published in the New England Journal of Medicine called Diagnostic Criteria for Non-Viable Pregnancy Early in the First Trimester. That I was the moderator of that consensus conference. The conference included radiologists, obstetrician gynecologists, and emergency medicine physicians. And I think it's had a significant impact. The criteria from that consensus conference and from work of others has really gone a long way to standardizing the criteria for diagnosing miscarriage that are used all over the world. One of the driving forces or very important considerations that we took into account and that have to be taken into account in diagnosing miscarriage has to do with the consequences of false positive and false negative diagnosis of miscarriage. In medicine, whenever we use tests to make diagnoses, there's always the chance of false positives and false negatives. Now, no tests are perfect. So for miscarriage, let's take a look at the false positive and negative diagnoses of miscarriage and what their consequences are. So let's start with a false positive. A false positive diagnosis of miscarriage simply means the erroneous diagnosis. You make an error. You say there is a miscarriage, but you're wrong. There isn't. What's the consequence of that kind of false positive? Well, the consequence is pretty horrible. The woman, if you make a false positive diagnosis of a miscarriage in a woman, she is likely to undergo a procedure such as uterine evacuation, evacuating out the contents of the uterus if you've diagnosed that there's a miscarriage, in a woman who has a potentially normal intrauterine pregnancy. That is a really horrible consequence. What about a false negative diagnosis of miscarriage? What do I mean by that? I mean, you should diagnose miscarriage. There is a miscarriage, and you should diagnose it, but you don't. The negative consequence there is delayed intervention for a woman with a miscarriage or with a failed intrauterine pregnancy. That's not great, but it's not so horrible. False positive, the consequences of a false positive diagnosis are much greater than the consequences of a false negative diagnosis. So we really want to avoid false positive diagnoses. So the criteria for diagnosing miscarriage should be set to eliminate false positives, to make sure that we never say to a woman, you have a miscarriage, when she really doesn't. And criteria for miscarriage should also be set to apply to a broad range of ultrasound facilities that meet at least minimum quality criteria to be doing ultrasound. Those criteria, we're not setting criteria that apply solely to experts in early obstetrical ultrasound. As we'll see as the talk goes on, that there are a number of outmoded concepts in early pregnancy that can lead to errors in diagnosis of miscarriage or errors in diagnosis of what's going on in an early pregnancy. Those outmoded concepts include pseudo-gestational sac, some of the published signs of early pregnancy, including the double sac sign and intradecidual sign. Both of those concepts, the pseudo-sac and the sonographic signs of early pregnancy, are about 35 years old now, from the early 1980s, and they're outmoded or obsolete now, as we'll see. Other outmoded concepts that lead to problems include overly lax criteria for miscarriage, such as an embryo measuring at least 5 millimeters with no heartbeat, or a mean sac diameter measuring at least 16 millimeters with no embryo. Finally, the notion of an HCG discriminatory level for excluding a normal intrauterine pregnancy is another outmoded or obsolete concept. And we'll see as we move along this talk why all of these are obsolete and what kinds of errors you can make if you use them. So we're going to consider here 3 scenarios in the diagnosis of early first trimester miscarriage. One is, these are all in women with positive pregnancy tests. Scenario 1 is when you don't see an intrauterine pregnancy, and you also don't see anything in the adnexa. That is known as a PUL, which stands for pregnancy of unknown location. Another scenario in which we diagnose or try to diagnose miscarriage is when we see an intrauterine pregnancy, as this small little fluid collection here represents. but there's no heartbeat, diagnosing miscarriage in those settings. And the third scenario that I will consider is when the ultrasound shows an intrauterine pregnancy with a heartbeat. So the topics are going to that I'm going to cover. First, I'll briefly talk about normal ultrasound findings in the early first trimester, and then get into scenarios 1, 2, and 3 after that. So let's start with normal ultrasound findings in the early first trimester. The ultrasound findings between 5 and 7 weeks follow a very well-defined sequence with very little variation from patient to patient, from woman to woman. These ages that are listed on this slide are what we see on transvaginal ultrasound. Transvaginal ultrasound is the technique that should be used in the first trimester, especially when an abnormality is suspected. So what happens very predictably, as you can see on this slide, is that at 5 weeks we see a gestational sac. That by 5 weeks I mean the time since the number of weeks since the woman's last menstrual period, which is how we standardly define age or measure age in pregnancy. Gestational age is the same as what's sometimes called menstrual age since last menstrual period. So at 5 weeks we see a gestational sac. At 5.5 weeks, or very, very close to that, we first see the yolk sac. At 6 weeks we first see the embryo with a heartbeat, and then a week after that, at 7 weeks, we start to see the amnion around the embryo. So here are examples on ultrasound. At 5 weeks, you can see the pregnancy looks like a little round or oval fluid collection in the central bright part of the uterus, as seen here. At 5.5 weeks, we see a yolk sac, but still no embryo. At 6 weeks, we're seeing this tiny little, this is 1 or 2 millimeters, this embryo. We see it at 6 weeks. You can see the heartbeat within it. And at 7 weeks, you can see that we're seeing not only the embryo and the yolk sac, but we're seeing the amnion that is separate from the embryo. Where's the amnion back at 6 weeks? It's really right up against the embryo, so we just don't see it. It separates from the embryo in the normal pregnancy at 7 weeks. So these dates, 5 weeks, 5.5 weeks, 6 weeks, 7 weeks, are very, very precise from woman to woman. How do we actually diagnose an early intrauterine pregnancy? Well, in a woman with a positive HCG who has a little intrauterine fluid collection on ultrasound, if that fluid collection contains a yolk sac or an embryo, we know it's a gestational sac. But an important question is, if the fluid collection does not contain a yolk sac or embryo, how can we tell whether it is a gestational sac? And here's an example. This is a woman who has a history of pelvic pain. Her HCG, her pregnancy test, measures at 1800. And on ultrasound, we see a little small non-specific fluid collection in the uterus. By non-specific, I mean it doesn't have any particular features or signs. It's just sitting there in the middle of the uterus. Her adnexa were normal on other images. So again, positive pregnancy test at 1800, small little non-specific fluid collection in the uterus with normal adnexa. So think about, for the next few minutes, we'll get the answer soon, is the most likely diagnosis here an intrauterine pregnancy? Or does this woman with a positive pregnancy test is the most likely diagnosis an ectopic pregnancy with a pseudogestational sac or an ectopic pregnancy with a decidual cyst? Or should you say, I just can't tell? And if I were issuing a report on this patient, should your report say, I can't tell, the findings are consistent with either intrauterine pregnancy or ectopic pregnancy? Right around the late 1970s, early 1980s, two sonographic signs of early intrauterine pregnancy were published. The so-called double sac sign, which you see here, a little fluid collection surrounded in part at least by two bright rings. And if you look at the diagram, remember that pregnancies are not situated in the cavity of the uterus. That's that little black area down here. They burrow into, they're situated within the decidua, which is really just the endometrium of the uterus. So the double sac sign arises when you see a ring here and a ring here surrounding at least part of that fluid collection. That's a double sac sign. Or in other patients, what you may see is this little white line, which corresponds to the collapsed uterine cavity, and the fluid collection sitting beside it. So here is that thin white line, little fluid collection beside it, and that tells us that the fluid collection is not in the cavity, but in the decidua or the endometrium. So those two signs were published 35 years ago. But today, we see pregnancies very early, and many pregnancies, we'll see how many very shortly, many pregnancies have no sign. This is an early pregnancy. How do I know it's an early pregnancy? Because she came back a short while later, not too many days later, and there was an embryo with a heartbeat, which we're not seeing here. So this is what I would call a pregnancy with no sign. It's just a non-specific sac-like fluid collection in the middle of the uterus. So how do we know whether something like this is a pregnancy or what used to be called a pseudogestational sac? Because after all, we don't see an embryo, we don't see a yolk sac, we don't see a double sac sign, we don't see an intradecidual sign. How do we know what it is? Well, to try and answer that question, we in our own department in Boston did two different studies. We looked in intrauterine pregnancies how often they had a nonspecific sac-like structure and no double sac sign or no intradecidual sign. And we found that about 50% of early intrauterine pregnancies today look like a nonspecific sac-like structure. How often does an ectopic pregnancy also have a little nonspecific sac-like structure in the uterus? Well, we found that with ectopic pregnancies, most women have no fluid in the uterus. Some patients have a little bit of irregular fluid that doesn't look like a pregnancy. And about 3% of women with ectopic pregnancies have a similar kind of non-specific sac-like structure in the uterus. So you can see when you look at comparing this piece of the pie to this piece of the pie, most non-specific sac-like structures are actually intrauterine pregnancies. Very few of them are ectopic pregnancies. But if you also factor in the relative incidence of intrauterine versus ectopic pregnancies, 98% of pregnancies, at least in the United States, are intrauterine, only 2% are ectopic. Now compare the size of this piece to this piece, and you'll see that almost every time you see a nonspecific sac-like structure, it's an intrauterine pregnancy. Very rarely is it a sign of ectopic pregnancy. And if we do a little calculation based on these numbers, the incidence of ectopics in all pregnancies is 2%. 50% of early intrauterine pregnancies appear as a nonspecific sac-like collection in the uterus, and 3% of ectopics have that kind of appearance. If we do a little math, we can see that an isolated sac-like fluid collection in the uterus, by isolated I mean there's no adnexal mass of an ectopic pregnancy. Anytime you see an isolated sac-like fluid collection in a woman with a positive HCG, there's an over 99% chance that it's a gestational sac, less than 1% chance that it's a pseudo-gestational sac or a decidual cyst. And therefore, basically, anytime you see an isolated sac-like fluid collection in a woman with a positive pregnancy test, it's almost certain to be a gestational sac. It's a highly likely gestational sac in such a patient, and whenever you see a little fluid collection in the uterus in a woman with a positive pregnancy test and nothing in the adnexa, any treatment that could damage an intrauterine embryo, such as methotrexate or a D&C procedure, any such treatment should be avoided unless a normal intrauterine pregnancy is definitively excluded at some future time. So I posed this question a few slides ago. This woman has an HCG, a pregnancy test measurement of 1800. She has a small, nonspecific fluid collection in the uterus. What's the most likely diagnosis? It's an intrauterine pregnancy, none of the others. And 16 days later, there's the embryo with a heartbeat. So these kinds of things in women with positive pregnancy tests are virtually always intrauterine pregnancies. Okay, so let's move now to diagnosing miscarriage. Now that we know that what early pregnancies look like, they really look like any little fluid collection in the uterus. Let's look at diagnosing, at scenario 1 of diagnosing early first trimester miscarriage, where you see nothing in the uterus. So the setting here is ultrasound shows no intrauterine pregnancy and shows no ectopic pregnancy in a woman with a positive HCG. She has a pregnancy of unknown location because we don't see it inside or outside the uterus. And the main question here, can a single HCG value, the discriminatory level, diagnose or exclude any one of a normal intrauterine pregnancy, miscarriage, or ectopic? Is that discriminatory level that's been described, and we'll see in a minute what it means, is it useful to diagnose, to conclude what's going on? So what is the HCG discriminatory level? It's a concept that was originated by Nicholas Kadar in 1981, 34 years ago, and it's defined as the HCG level at or above which a normal intrauterine pregnancy is consistently seen. In 1981, Kadar reported the discriminatory level to be 6,500, which meant that, in other words, he found that in women with normal intrauterine pregnancies, you always saw a pregnancy in the uterus on ultrasound if the HCG was 6,500 or above. As ultrasound technology improved, the discriminatory level dropped. The level at which we always see an intrauterine pregnancy, if there's a normal one, dropped. And since about 1990, when transvaginal ultrasound became commonly used in early pregnancy, the discriminatory level has been reported to be in the 1 to 2,000 range. In other words, if we take the higher number, by the time an HCG, the HCG is at least 2,000, if the discriminatory level works, by the time it's 2,000, you should always see a pregnancy in the uterus if there's a normal pregnancy. So the rationale, just by pictures, is that if the HCG is greater than 2,000 and you see no intrauterine fluid collection, the rationale for the HCG is that in that kind of situation, the woman can't have a normal intrauterine pregnancy. The differential diagnosis then in a woman with an HCG above 2,000 and nothing in the uterus would be either a failed intrauterine pregnancy, a miscarriage in other words, or an ectopic pregnancy. And based on that rationale, at least two different management algorithms came into common use. First said if the HCG is above the discriminatory level and you don't see an intrauterine pregnancy, you should do a D&C. And if you don't see any chorionic villi on the D&C, treat for ectopic pregnancy. And another management algorithm that was proposed is if the HCG is above the discriminatory level, usually taken as 2,000, and you don't see an intrauterine pregnancy, just go straight to intramuscular methotrexate for a presumed ectopic pregnancy. Well, that's the theory and the rationale, but here's the reality. Here's a woman, an ultrasound, a woman whose HCG is over 4,000, more than double the usually considered discriminatory level of 2,000. There's no visible gestational sac. If the discriminatory level worked, this woman couldn't have a normal intrauterine pregnancy. But look, a month later, she has a normal 9.5-week intrauterine pregnancy and ended up with a normal term baby. So the discriminatory level did not work in this woman and in many others for ruling out a normal intrauterine pregnancy. And therefore, with respect to the HCG level and pregnancies of unknown location, in other words, the HCG level in women with no visible intrauterine or ectopic pregnancy, the important rule to follow is that if ultrasound shows no evidence of an intrauterine or ectopic pregnancy, don't intervene based on a single HCG measurement. And that's because a single HCG measurement, even if above what's sometimes called the discriminatory level, does not rule out a normal intrauterine pregnancy. It's important to get at least one follow-up ultrasound and HCG in order to avoid damaging a potentially normal intrauterine pregnancy or giving methotrexate unnecessarily to a woman with a failed intrauterine pregnancy. Okay, let's move on to scenario 2 in diagnosing miscarriage, where you do see an intrauterine pregnancy, but you don't see a heartbeat. So scenario 2, just to state what we're looking at here, the ultrasound shows an intrauterine pregnancy. There's no heartbeat seen, maybe just no embryo, or an embryo with no heartbeat. The questions there are, in scenario 2, what findings indicate a definite miscarriage and what findings are suspicious for miscarriage? So there are really 3 different criteria for pregnancy failure or miscarriage on ultrasound. One is failure to visualize a heartbeat by a certain embryonic size, in other words, a crown rump length without a heartbeat. Another is failure to visualize an embryo by a certain gestational sac size, in other words, a mean sac diameter without an embryo. And the third type of criteria for miscarriage are failure to see an embryo by a certain point in time, and that's usually defined as no embryo seen after some time interval since an initial ultrasound. So the criteria up to about 2012 that were in pretty broad use were a crown rump length of at least 5 millimeters without a heartbeat, indicated definite miscarriage, a mean sac diameter of at least 16 millimeters without an embryo, indicated definite pregnancy failure, and there were no well-established criteria for non-visualization of an embryo by a certain point in time. So let's look at each of these. The crown rump length, with respect to the crown rump length, the heartbeat is usually seen as soon as the embryo is visible. This is a crown rump length of 1.7 millimeters. Should be seeing a heartbeat here, as we do right now. But to diagnose miscarriage with certainty, the question isn't that we should be asking is not when we usually see a heartbeat, but when we always see a heartbeat. At what crown rump length do we always see a heartbeat if the pregnancy is normal? So in other words, what's the cutoff value of the crown rump length above which cardiac activity is always visible on transvaginal ultrasound in a normal pregnancy? And early studies in around 1990 suggested 4 or 5 millimeters. In other words, those early studies indicated that by the time the crown rump length is 4 or 5 millimeters, if you don't see a heartbeat, it's never going to be there. It's a miscarriage. So 5 millimeters became the generally accepted cutoff for diagnosing miscarriage. But what we've come to realize over the last few years is that 5 millimeters is not good enough. Occasionally, studies have reported women with whose ultrasound shows a 6 millimeter embryo with no visible heartbeat who then came back on follow-up and everything was fine. So the SRU consensus panel in 2012 and the publication in 2013 raised the cutoff from 5 millimeters to 7 millimeters, stating that the new criteria for miscarriages, a crown rump length of 7 millimeters or greater and no heartbeat being definitive for miscarriage. And then if you have a crown rump length, anything under 7 millimeters and there's no heartbeat, it's highly suspicious for miscarriage. Just a couple of examples. Here's a 7 millimeter embryo on the video clip. There's no heartbeat. That shows definite miscarriage. Here is a 4 millimeter embryo with no heartbeat. That's suspicious for miscarriage. What about the mean sac diameter? Here the question is, what is the cutoff value for the mean sac diameter above which an embryo is consistently visible on a transvaginal ultrasound in a normal pregnancy? Early studies suggested that by the time the mean sac diameter was 16 or 17 millimeters, you always see an embryo if the pregnancy is normal. So 16 millimeters became the generally accepted cutoff for diagnosing miscarriage. In other words, if you have a 16 or greater millimeter embryo, mean sac diameter, and you didn't see an embryo, you could diagnose miscarriage with certainty. But again, studies around the year 2010, a couple of years before or after, showed that 16 millimeters was not good enough. There have been reports of mean sac diameters greater than 16 millimeters, a little greater than 16 millimeters with no embryo that proved to be normal on follow-up. So the SRU consensus panel increased the cutoff from 16 millimeters with no embryo to 25 millimeters and no embryo being definitive for miscarriage. Anything between the old cutoff of 16 millimeters and 24 millimeters in the absence of an embryo is suspicious but not definitive for miscarriage. So here's an example of a definite miscarriage. We have 3 measurements of this gestational sac. 1, 2, 3. We average them, 27.7 millimeters, no embryo. That's bigger than the cutoff of 25 millimeters. This is definite for miscarriage. Here, we take the 3 measurements, we average them. It's measuring 16.8 millimeters, and there's no embryo. This is suspicious, but not definite for miscarriage. And then the SRU Consensus Conference also came up with some time-based criteria for miscarriage. If you see a gestational sac without a yolk sac, in other words, one of those little tiny fluid collections on an initial scan, and then there's still no embryo at least 2 weeks later, that's definitive for miscarriage. If you see on the initial scan a gestational sac with a yolk sac and you still see no embryo 11 days later, that is definitive for miscarriage. And then some different time criteria for to be suspicious for miscarriage. Here's an example based on time-based criteria of a definite miscarriage. On initial scan, we see a gestational sac with a yolk sac. 12 days later, we're still seeing a yolk sac, but there's no embryo. That 12 days is above the 11-day cutoff, so this is a definite miscarriage. And there are a couple of other ultrasound criteria that are suspicious for miscarriage. One is an empty amnion. The amnion is adjacent to the yolk sac and there's no embryo, or a large yolk sac. Here's an empty amnion. We see two little circles. One is a yolk sac and one is an amnion. I'm not even sure which one, but remember from an earlier slide where I showed you the normal progression of ultrasound findings in pregnancy, we normally see the embryo at 6 weeks, the amnion at 7 weeks. The amnion, in other words, comes after the embryo. Here we're seeing an amnion with no embryo, so it's abnormal, suspicious for miscarriage. And here are a couple of different pregnancies with a large yolk sac, bigger than 6 or 7 millimeters, that are suspicious for miscarriage. And here is a full listing of all of the diagnostic criteria that are definite for pregnancy failure or suspicious for pregnancy failure. And these come from our New England Journal article publication. And the final scenario that I will consider, scenario 3, is diagnosing miscarriage, or at least impending miscarriage, when you see an intrauterine pregnancy with a heartbeat. So here the question is, what findings suggest impending miscarriage, a miscarriage about to happen within the next few days if an ultrasound shows an intrauterine pregnancy with a heartbeat? There are a number of findings that suggest impending miscarriage, such as a slow or irregular embryonic heartbeat, a large subchorionic hematoma, and some others. I'll go through these briefly. First, early heart rate. The main numbers to remember here are that very early on, up to about 6.2 weeks of pregnancy, or up to a crown rump length of 4 millimeters, the heart rate is slow if it's less than 90 beats per minute, and it's normal if it's at least 100 beats per minute. If there's a slow heartbeat, that is suspicious for impending miscarriage. There isn't a miscarriage yet because there's a heartbeat, but it's suspicious for impending miscarriage when the crown rump length is 5 to 9 millimeters. Anything under 110 beats per minute is suspicious for impending miscarriage. And here's an example. You can see this embryo with a heartbeat, 4 millimeter embryo with a heartbeat. It's going at 82 beats per minute. It looks slow to our eyes, going at 82. This is very suspicious for impending miscarriage. And sure enough, 5 days later on this clip, there's no heartbeat. Now here, if you look, you can see beat, beat, stop, beat, beat, stop, beat, beat, stop. On the M mode, beat, beat, stop, beat, beat, stop. This is an irregular embryonic heartbeat, also suspicious for impending miscarriage. What about when we see a subchorionic hematoma in conjunction with a heartbeat? So we do an ultrasound, we see an embryo with a heartbeat inside a gestational sac, but there's a hematoma around the sac. What is the clinical significance of that? Subchorionic hematomas have been classified as small, medium, or large based on subjective assessment, what it looks like, based on the fraction of the gestational sac that's surrounded by a hematoma. Is it a quarter surrounded, a half surrounded, all surrounded by hematoma, or the estimated volume of the hematoma? Whichever method you use, subchorionic hematomas can be classified as small, medium, or large. Most studies of subchorionic hematoma in the presence of an embryonic heartbeat have found that a large subchorionic hematoma carries a somewhat elevated risk of subsequent miscarriage likelihood of miscarriage around 20 to 40%. So in other words, if you see an ultrasound today and there's a heartbeat and there's a large subchorionic hematoma around the gestational sac, there's about a 20 to 40% chance that the pregnancy will miscarry. There's still a 60 to 80% chance that it will do fine, but about a third of those cases with a large subchorionic hematoma and a heartbeat will miscarry. A small to moderate subchorionic hematoma really doesn't mean anything. If there's a heartbeat, they carry little or no added risk of miscarriage happening. So here's a case where you see a heartbeat right here, but there's a pretty large subchorionic hematoma. Here's one part of it. That's that same part. It also goes around here. Really, all of this part of the gestational sac is surrounded by a subchorionic hematoma. This is a large subchorionic hematoma measured by any of the methods that I showed on the prior slide. This is suspicious for impending miscarriage. On the other hand, this is a small to moderate subchorionic hematoma. There's a heartbeat. There's little or no risk to this pregnancy. And 5 weeks later, you can see everything looks fine. We sweep through and the hematoma's all gone. So small to moderate subchorionic hematomas really don't mean anything. Another finding that is suspicious for impending miscarriage is a small gestational sac size when there's a heartbeat. Here's an embryo. You can see the fetal head, the body, the heartbeat, but the sac is hardly bigger than the embryo. Very little fluid around the embryo. That's a very worrisome finding. This was just over 7 weeks. So this is worrisome for impending miscarriage, and in fact, there was a demise on a follow-up scan 6 days later. Another finding in conjunction with heartbeat that's suspicious for impending miscarriage is an expanded amnion. Again, the amnion normally appears at 6.5 to 7 weeks, usually 7 weeks when the crown rump length is close to 10 millimeters. If we see an amnion when the crown rump length is less than 5 millimeters, there's a very high chance of subsequent miscarriage. As in this case, here you can see there's a heartbeat on this clip. There's the yolk sac, but what's abnormal is there is the amnion around it, even though the crown rump length is only about 3 millimeters. You really shouldn't see it until it's close to 10 millimeters. You shouldn't see the amnion. This is highly worrisome, and in fact, a week later on this clip, there's no longer a heartbeat. I said earlier that a enlarged yolk sac bigger than 6 or 7 millimeters, when it's seen alone, is worrisome for miscarriage. If you see an enlarged yolk sac in the presence of a heartbeat, it's suspicious again, but now for impending miscarriage. Here's an embryo with a heartbeat, going a nice normal rate, but the yolk sac's too big. The yolk sac is 9 millimeters. Bigger than the 6 or 7 upper limit of normal, and on follow-up, there was a demise, follow-up a month later. So just to summarize, in a woman with a positive pregnancy test and no adnexal mass, if the ultrasound shows no intrauterine fluid collection, so there's no adnexal mass and no intrauterine fluid collection, she has a pregnancy of unknown location, it's important not to intervene before getting a follow-up HCG and ultrasound. If the ultrasound shows an intrauterine fluid collection with rounded edges, it's likely an intrauterine pregnancy, so don't intervene. And if the ultrasound shows an intrauterine pregnancy and no cardiac activity, don't intervene unless the ultrasound findings meet very strict criteria, the 7 millimeter crown rump with no heartbeat or the 25 millimeter with no embryo. Don't intervene unless the ultrasound findings meet strict criteria for failed pregnancy. pregnancy. Notice the don't intervene, don't intervene, don't intervene. Don't intervene unless you're really, really sure that it is a miscarriage. The bottom line message is, first, do no harm to early pregnancies. Thank you.